Well, good afternoon, everyone, and thank you so much for being here. I hope you walk away with just a really, not only being inspired by these stories, but with just an incredible amount of new information that will help you think about cancer risk and prevention differently for your own families. I want to talk about just a couple of things before we get started. First of all, this is our 20th anniversary as the Community Health Endowment. We're really excited about celebrating that, and we're doing that this year by having 20 birthday parties in the community. And we've already finished 8 of those, but there are some that are coming up. We're having some all year. And so if you look at this sheet of paper, this little card that is in front of you, you will see the next 3 that are coming up, because one of these we just finished last week. And of course the one is today, but we have 2 more. One of them will be held on November 8th. It's a series of yoga and Tai Chi and Qigong, a series of those particular techniques that will be held with a master who is originally from Mongolia, but he trains in these across the country and around the world. And so he's going to be in Lincoln. So if you're looking at getting just a taste of any of those, or if you want an experience from a trained master in those fields, this would be a great opportunity for you. And we're also doing another event called a Poverty Experience. It puts you in the shoes of someone who's experiencing poverty in our community and walks through that experience using actors and other people in the community who are playing the roles of people that a person in poverty would interact with on a daily basis. And so it's really a very interesting process, and we would welcome you to come to that particular event on November 14th over at City Impact. All of these are free and open to the public, and even if it's something that maybe you're not able to come to, feel free to share this with your friends and neighbors and colleagues. So again, thank you for being here as we explore the topic of cancer today. As you know, it's an incredibly important topic, and these folks are here to not only share their expertise with you, but their experiences, which I know are going to be incredibly fascinating and important to all of us. I'm going to start at this end with Katie. Katie Anuka is a 30-year-old stay-at-home mom. She has 2 children, Olivia, who is 3, and Carter, who is 1. She was just diagnosed with stage 2A estrogen receptive breast cancer in late June of this year. She had discovered the lump in her left breast 4 months after she stopped breastfeeding, but she assumed that it was perhaps a clogged duct, and so she perhaps put her mind at ease a little bit, but she also thought about the fact that her mom was a 14-year cancer survivor. So she decided to get it checked out, and she had a double mastectomy just on August 20th. You look terrific. Thank you. Yeah. She's currently undergoing chemotherapy. She did get genetic testing, and she learned that she carries the CHEK2 gene mutation, which I'm sure she'll tell you about. But what she says is, while I'm not glad I have this genetic mutation, I now have the information I need to get my children screened early. So that's exactly what we hope all of you will be thinking about today. Her mother does not have the mutated genes, but her dad is in the process of getting checked. So thank you for being here very much. I also want to tell you about Bronson Riley. Bronson is a certified genetic counselor and a clinical research director for the Southeast Nebraska Cancer Center, as well as an adjunct faculty member at the Union College Physician Assistance Program. So he is a busy guy. He was the first genetic counselor to be licensed to practice by the Nebraska Board of Medicine and Surgery, and has been practicing clinically for over 13 years. So you've seen a lot in those 13 years. Prior to his graduate training at Case Western University, he worked as a registry coordinator and a genetic research associate with Dr. Henry Lynch at Creighton University's Hereditary Cancer Institute. He was the recipient of the New Leader Award by the National Society of Genetic Counselors, where he was a past executive board member, and the lead author of the most recent Society of Genetic Counselors Cancer Genetic Counseling Practice Guidelines. This year he was elected to the American Board of Genetic Counseling. So great expertise in the room. And we also have Brandy Preston. Brandy was born and raised in Omaha, Nebraska. She is the founder of the Cammie K. Preston Hereditary Cancer Foundation in honor of her mother. The foundation raises awareness about hereditary cancer syndromes while improving access to genetic testing. Brandy's mother was only 35 years old when she was diagnosed with aggressive breast cancer, and she spent many summers in hospital waiting rooms with her siblings as her mother underwent chemotherapy and radiation. That's where she learned about the genetic mutation her mother carried, a mutation that she had a 50-50 chance of having. As her mother's cancer progressed, Cammie asked each of her children to learn their risk and to be proactive about their health rather than reactive. And Cammie passed away on July 27th, 2005, but Brandy fulfilled her promise to her mom, and she had that genetic testing done on her 19th birthday and learned that she too carries the BRCA1 mutation. That gives her an 87% lifetime risk of breast cancer and a 63% lifetime risk of ovarian cancer. She had a prophylactic mastectomy at age 22, and she no longer fears suffering from or losing her life to breast cancer. BRCA has been a gift, she said, although not wrapped very beautifully. It has given me the ability to take control of my health and to encourage others to do the same. You know, their stories are very powerful. My mom, as many people today, my mom was a breast cancer survivor. I know the feeling of living with someone as a small child, especially. Brandy and I were talking about this ahead of time. I was just 10 when my mom was diagnosed. And it's a journey. Every one of these stories is a journey. Sometimes it affects us all for the rest of our lives, but today is an opportunity to maybe put all of our stories on a little different trajectory and really think about, as these folks have already told, about something positive that can come out of this experience. So I'm going to turn this over to Dr. Eric Avery. He is your moderator for today. He was born in Grand Island, completed his training at UNMC with board certifications in internal medicine, medical oncology, and hematology. He works at Nebraska Hematology Oncology and sees patients with any cancer or blood disorder. He's published papers on lung cancer and breast cancer and is a member of multiple medical committees across the community. He enjoys, and I like this, he enjoys hunting, fishing, and killing cancer cells. So as you can see, we have an absolutely awesome panel today, and I know you guys are going to feel the same.
The topics today, and I'll really kind of turn this over, is to get talking about breast cancer. How do we further not only evaluate for ourselves, but our overall risk factors for ourselves, our families, and getting into all the different resources that are available for that. With that, there is the getscreened.net, the website for that, and I'd like to turn it over to Brandy for that.
Yeah, so this is a really exciting website. So it has a lot of facts on there about screening focused on colon, breast, and cervical cancers. Today is really exciting because it's the kickoff for a year-long campaign that's going to focus on encouraging people to get screened for these different cancers. What's exciting is that colon cancer, a lot of people don't realize, is 100% preventable. You find a polyp, you remove it, you don't develop colon cancer. Breast cancer, there's a lot we can do for screening, and then cervical cancer, we have a vaccine that can help with a lot of those too. On that website, there are 2 documents that you guys should all have in front of you that are pretty awesome. Your family medical history, and my favorite part about this is that it includes history from both your mother and your father's side. That's a common misconception. I don't know if you guys run into this too, but so many people don't realize that these cancers can be inherited from either your mother or your father's side, so knowing that history on both sides is critically important. But also knowing your own personal risk factors, and so that's what the second handout is, and it goes over a lot of different things, both family history and genetics, but just environmental factors too, like when did you have your first baby, have you had a baby, those kind of things. So those are both on that website, which is pretty awesome. And there's going to be videos, I think Lori said we might watch those later today, that are going to be on there too, about having, about gathering your family history. What does that look like when you're talking to family members? And then if you test positive for a mutation, or if you're just high risk in general, having those conversations with your family members. So those will be on that website too. I think that's it.
So with the Get Screened website, that's really important. One of the things being is, I was just seeing somebody today who is being treated for her breast cancer and actually has done genetic testing. And today she brings in her results and she's really happy because it was completely normal. Well, she doesn't have a lot of family history. She had genetic testing that was done. And she said, so I'm good, right? Well, no, you're still, if you live on this earth, you still are exposed to solar radiation. You're exposed to all the different environmental factors that can happen that increase our risk for developing cancer, whether it's breast cancer or colon cancer or any of those. So people still need to be screened, and you still need to go through the different screening processes, even without an appropriate family history. And Bronson, if I may, I'd like you to touch on that for a moment. Or, what kind of percentages do we look at when we talk about a big population? If we look at America, how many of those people really generally have a genetic predisposition for cancer?
So our current understanding is about 5 to 10% of people have an identifiable gene mutation that's causing their cancer, right? And then there's another 10 to 15% that have roughly what we call like a familial risk. And so that means that they've have a history of cancer in the family. It could be contributing to their risk as well. And but we may have not identified a specific gene mutation yet, but they are still at an increased risk. And so are following those high-risk protocols where they don't have cancer, but they're doing cancer screening that's above and beyond what's seen in the general population. And so you nailed it along those same lines. A woman can undergo genetic testing and have negative test results and can still fall into that increased risk category. And so that was the concern when all this genetic testing was coming out in the early 2000s, was that people would undergo this testing, and exactly what you described, Dr. Avery, tested negative, they're in the clear. And a lot of you heard Katie has a CHEK2 mutation, and we were doing genetic testing, again in the early 2000s, where we're just looking at BRCA1 and BRCA2, which account for about 50% of families with hereditary breast and ovarian cancer, but there's still another 50% of families that have hereditary breast and ovarian cancer and either have a mutation in a different susceptibility gene, or we haven't figured it out yet. And so those family members are still at risk and still should be following high-risk protocols until we can figure it out. And they're not in the clear. But sometimes what frequently happens is someone gets negative test results, and I've been in the same, and you kind of like, yes, and you turn your brain off and you're excited, and then you don't hear anything else after that conversation, And so it's something that a lot of our primary care colleagues, we need to educate them to say, look, you're doing this genetic testing. If it comes back negative, still don't ignore that clinical feeling of like, they still have a really strong family history. Something still could be going on. Let's manage them accordingly.
Thank you. And so part of this also is screening, talking to your family, talking about the family history. I don't know if your family tree is probably nothing like my family tree. It's probably well pruned and everything. But, certain family trees, sometimes people don't talk about their history. Sometimes people don't want other family members to know of something that's going on, and that's normal, and it's okay. But starting that conversation can be really important. Brandy, you were saying on with your information, not only looking at the personal risk and looking at your family risk, that really puts those risk factors into place so that we can calculate a score. But this is life. We can't always calculate every score, and we can't predict everything. And so really it does still come back to monitoring and trying to prevent as best we can and trying to screen where we can. And so as we talk more to our family about getting that information to not only assess our own personal risk or our siblings' risk or our children's risk, and allowing you to give that information to your provider, what are some different ways in talking to the family about that? And I mean, for the screening purposes of this is talking about the breast and colon and cervical. These are very, well screened and very well treated cancers that we can, cancers that we can really treat and have a lot of options for. But it also applies to other cancers too. And so we can't include all the information for every single one of those today. But Bronson, can you talk also about how to start that conversation with your family?
And it can be a loaded conversation, and you'll see in these great videos that they'll show is that, this goes without saying, but illness and death can be very traumatizing for family units, and broaching those topics can reveal or reopen certain wounds. And so when I see people that are going to go talk about or inquire about their family history, the first thing is to do a little bit of homework. If the person that you're talking to, the first thing I want you to do is to look out how closely they are related to the person that you want information about. Are they a first-degree relative? If they're a first-degree relative, how close were they as part of their care? Were they their primary caretaker, or were they living clear across the United States? Like, what was their relationship like with the person that you're inquiring about? And be aware of how that can be perceived as someone that's coming and asking all these very specific questions. Brandy talked about being that kid in the hospital, and people are looking at her with, concern, and it kind of gets annoying. Like, be sensitive to that person that you're inquiring. And at the same time, the second bit of homework I always encourage people to do is to be aware of your own relationship with them. If you haven't talked to this cousin in 20 years and you pick up the phone and say, "Hey, how did your mom die?" How do you think that's going to be perceived, right? And so do your homework. Make sure that if you haven't talked to them in a while, just don't jump right into the topic, but do some small talk. And then be upfront at the beginning why you're asking this information. Because, I always joke, because I've been practicing in Nebraska this entire time, but Dr. Avery we don't talk about it. I don't know if it's a cultural thing, if it's a German thing, if it's a Czech thing, if it's we just don't talk about it. My first year as a genetic counselor, I had a mother and daughter that I was seeing for genetic testing, and that mother had gone through diagnosis and treatment, and daughter did not know about it. Because she didn't want, I don't want to say classic Nebraska mom, but she didn't want them to worry. She wanted to take care of herself, and she didn't want to worry her kids. I was like, that's great. But when it comes to family history now, and when it comes to your kids' care, having that information is very important. And so my third bit of kind of information with regarding to collecting your family history is the way that you document it is very important. And there's a lot of resources that are available online about documenting your family history. But the important thing is, once you have it documented, share it with other family members. I have it on my to-do list, but I want to write our family book. It's not anything we're going to publish, but it's just information about all the family members that are still around, because they may not be around, and then you lose that information. And so documenting not just health, the stories and all those different things that inform the culture and the story of your family, get that down on paper and share it with other people, because I guarantee, and it's not just cancer. That's the other thing. We're talking about cancer today, but it's going to be cardiovascular disease. It's going to be asthma. It's going to be diabetes. You're going to be asked these same questions, and it's not just cancer. So documenting that in a way that's easily shareable is really helpful for you and your family members. So speaking of, Katie, she had to go through this. She had to document her family history. She knew about her mom's family history. That informed you didn't ignore that lump.
I ignored my dad for quite a while.
Oh, yes, you did ignore that for a while.
So I have the CHEK2 gene, which affects prostate, breast, and colon cancer. My mom had genetic testing done. She was negative for CHEK2 and BRCA. So we assumed it came from my dad. My dad struggles with, he needs to blame something. He had prostate cancer. So to me, I was like, Dad, this may explain your prostate cancer. So I actually wrote down what I was going to say to my dad, so it would be a successful thing to ask him to get tested. I used my children as leverage. And I just explained to my dad that our family needs this information to confirm, yes, it came from you, so now I know what to do with my children. So I did have the conversation and it went well, and he did agree to get tested. And so we're in the process of working all that through. But since my dad's a sensitive guy, he wanted to blame me having cancer from him, which is not the case. He didn't give it to me. So that was a hard conversation to have, but I'm glad I had it, and now hopefully he will continue on with the testing. So
those are very difficult conversations to have, particularly with family who, just like Bronson said, I mean, it's often you don't want to hurt somebody's feelings. You don't want to scare them. You want to protect a family member or something like that. And so that's, it's a difficult topic, but it's still one of those topics we really have to have. And so, Brandy, do you mind sharing your experience of how did your mom kind of go through some of that with you?
Yeah, so my mom's family history is pretty extensive. On my mom's side, my grandma's side, there's 5 generations of breast, ovarian, and endometrial cancers. And so it was assumed for a long time that that's where the mutation came from. Through a research study with Dr. Lynch and Dr. Wang at UNMC, it was revealed that the mutation actually came from my grandfather. It didn't come from that crazy family history, but my grandpa's one of 5 boys. A couple of them have had skin cancer, but they were all farmers, so that was kind of dismissed as just exposure. And so when I went to my grandpa and said, hey, this is what this research study is revealing, would you be interested in being tested? He's like, oh, okay, I mean, yeah, sure, I guess I will. And I took the superhero approach with him. I didn't say, you might be at risk for prostate and male breast and pancreatic, because I know my grandpa, that's not going to work with him. But I said, Grandpa, think about all of your nieces that this could impact. Nobody else should go through what my mom had to go through. And so if we can prevent that for somebody else, then we should, and my grandpa was all on board. You can't tell the war hero that he might get breast cancer. It's definitely a different approach. So I find that worked well for him, and then now it's been up and over the family tree, and I just had a cousin test positive. She's in Omaha getting her first breast MRI today. And I think my grandpa resonated well with that superhero message. I said, look at now Ashley and Michelle know exactly what to do. And nobody else will have to go through what my mom went through, hopefully. So I think when you take that knowledge is power approach, sometimes genetics and family history can be really scary to talk about. But when you say there's something we can do about it, you're not saying you're going to get cancer. You're saying you might be at risk, and here are all the things that we can do to make sure that you don't. It's a totally different conversation. And now I feel bad for my grandma in a way, because she still has that cancer history, and really no explanation as to why. She thought she was BRCA positive, and then we confirmed that with testing that she's not, and it came from my grandpa. And now she's kind of back in that gray area between, she's in that familial risk, right? And so I think sometimes that's a little harder. Like, we have a very clear path and guidelines, and our kids have a very clear path. But sometimes I think BRCA and check, and sometimes I really do think they are a gift, because we know exactly what to do. Those in that gray area, they might get managed a little bit differently, but they don't have an answer as to what's causing the cancers in their family like we have.
Another tip, if you have someone that likes to talk finances, is that you can appeal to their financial well-being when it comes to genetic testing. Especially, we frequently talk about, like, if you have, let's say, a brother who has 5 kids, if he's tested and is negative, then he doesn't have to, or then his kids don't have to be tested. If he refuses to be tested, each one of those kids have to be tested individually, which can add up financially. And so that's another, if you have another relative that you're trying to convince to testing or get more information on, you can always appeal to their frugality.
That brings up a very interesting topic. I was talking to somebody the other day, just kind of at the grocery store sort of thing, and they said, oh yeah, I did 23andMe. My mom got that for me, 23andMe, and my BRCA's negative, so I'm good to go. Can I have you expound on that?
How much time do we have? Yes, so direct-to-consumer testing is not going away. So that's the first thing we have as people in healthcare have to be aware of, that is possible. People are hungry for genetic testing. They want to do it, and any way to do it, they'll get to it. I encourage, though, that when you do it with your physician, or you do it with a healthcare professional that's familiar with genetics, because, as Dr. Avery said, there are only three three BRCA and BRCA1, BRCA2 gene mutations on that 23andMe panel. They're only testing for 3. I think, how many are we up to now? How many identified mutation? Yeah, there's over 2,500 different documented BRCA1 and 2 mutations. And so having a negative test result on 23andMe only eliminates 3 of the 2,500. But if that testing is done without any healthcare provider guidance, that person may make the decision to not do a follow-up appointment, may not do breast cancer screening, may not, the potential exists that could cause more harm than good. And so always be savvy on the testing that you're doing, and then also read the fine print as to what is being done with your DNA after they collect it. Are they selling it to somebody else? Are they keeping it for research? What are they doing with it? Read the fine print, especially with the ancestry testing as well.
I have a family member who did the ancestry testing and now keeps getting emails. Oh, hey, this person may be a third cousin who just did the ancestry, and so it just keeps rolling through. And you have to protect that, just like you protect your Social Security number. Let's shift gears a little bit. Let's go into the videos on the communication strategies.
What did the doctor say?
Well, I'm fine. That's the first good thing to know. My heart's good, my cholesterol's good.
Good.
But there was one thing that the doctor asked me, and I need your help with this.
I hope I can help.
I think you can. It's about my family history. I've never really had to think about it before, but now I'm hitting 40, past 40 even, and now they want to know, what did your grandma have? Did she have cancer? Did your grandfather have heart conditions? I honestly don't know in some of these. I know that some of this stuff is hard to talk about, and it's hard for me to talk about it. But the doctor said it was important. And so we need to be as open and honest as we can be. And maybe, just maybe, it doesn't just, help me. I know that Melissa's kids would really benefit from knowing some of this stuff. My kids, down the road, would really benefit from it too.
Mm-hmm. Grandpa, he must have had prostate cancer.
Mm-hmm.
I think he was about 72 when that happened. But I really don't know a whole lot about him. I can tell you more about Grandma's side.
Okay.
Grandma, I think she was strong as a horse until her dying day. Her mind kind of got wiggly, but I think she was good.
Okay.
If you want to know all family history, Uncle Tim, he has a pacemaker, and he was only 42 when that happened. We don't know why Uncle Mark died. I don't know. He died when he was 47. I don't know if you would have remembered all that when that was going on.
No. Now, would Aunt Jenny remember what it was? Could I call her and talk to her about it, or is it just kind of sensitive right now?
Well, it's still, I don't know. I think it's fresh in my mind, but I think that she's willing to help people. She wants to help you, and knowing that if you explain to her that you're trying to get the information so that you can get the proper care, I don't know why. If you go about it that way, I think that she might be able to help you, and she's pretty willing to work with people, I think,
The doctor gave me this. It's just a basic chart a family medical history that lists basically it's almost a family tree, but for illnesses and that sort of thing, so that I can put this information down, and basically all I have to do is hand this to the doctor instead of having it written out and all in my chicken scratch right hand.
Well, and that would be good for the future to have. I mean, you may want to give a copy of that to your sister then too, for her to share with her kids.
It might even be good for you and Dad.
It might. Yes, I think our doctors would be interested in that too.
Absolutely.
Facebook's been really helpful when it comes to disseminating family information and collecting family history information. And so a lot of, if you don't have one yet, a lot of families have like private groups that then all the members of that family are in that, and then you can quickly message the entire group. I've had people during the consultation send a message to the entire family from the exam room and get a response back on a family member on an update. And so that has been very helpful in if you are in the process of doing that information or trying to share it. That's been a really helpful resource. Again, I don't know what happens to that information, but it is something that you can use.
It's so good to see you again.
Well, good. I'm glad you had some time. I wanted to kind of find a calm spot in your week so we could have a little face-to-face.
Sounds important.
Yeah, it is. It's not. It's a health thing, and it's some news. Not news exactly. It's just some information I wanted you to have so you could share it with the girls and like that. So.
Are you all right?
Yeah, I'm fine. I'm fine.
Okay.
I got through all the treatments and the whole thing, and all the checkups are fine. But part of what they do now when you've had cancer is they have you do some genetic testing.
Genetic testing after you already have it?
Well, it's to see, well, the likelihoods for your family and stuff like that. It's one of those things that it's important for you to know about it, and you're really freaking out, aren't you? I'm sorry.
Just a little bit.
Yeah.
But I'm listening.
No, we're on a calm Monday morning because I wanted to tell you about this in a kind of a matter-of-fact way, because it's a kind of a matter of fact. You know, it's knowledge is power.
Yes.
And one of the main things for you to know about this is that the fact that there's a certain gene in me doesn't mean it's in you, doesn't mean it's in the girls. Even if it is, it doesn't mean that cancer will automatically happen.
So you have this genetic testing, and you have a gene. We have a gene in our family.
It's the BRCA gene. I don't know if you've heard about any of this stuff.
Oh yeah, I think I have.
Okay, all right. Well, so it turns out that's part of my makeup, and so it would be a good idea for you to talk with your doctor about that. Now, I can share all the test results that I had. There's a whole bunch of information, much more than I'm telling you right now.
Do you have any brochures on this?
Yeah. This is a good starter. That's just generally about genetic testing and the results and what it means for people. I have a lot of links for information online and stuff like that. So, I mean, I don't know, it can be kind of overwhelming to be too informed.
True.
Sometimes the more you read, the more scary it is. But
well, we can maybe have a couple sessions like that.
Yeah.
So what I should do right away is go talk to my doctor, get an appointment.
Yeah, I mean, just give them a call and explain that I've been tested and I do have the BRCA thing, and what does he think about what you should do next. The other thing too is that when you want to talk to the girls about it, if you want me to be there, I could certainly be there and certainly tell them to call me with questions if they have questions.
Oh, I think that would be great if you were there.
Yeah. And we can go to my doctor if you want and kind of talk through the whole thing. So we'll just get as much information as we can in all the places so everybody's on the same page. And
I think I'd like you to go with me to my doctor. I think that would be very helpful.
Yeah.
Because I'm sure that there's information that you can give him that I would forget.
Yeah, and like I say, I can send I can have my doctor share stuff with your doctor, and that he can look at all the numbers and make sense out of it and all that stuff. But
That sounds great.
yeah, so I'd rather tell you I have a new job and I'm, the head of Microsoft or something. I wish it was that news, but.
Or that you won the Powerball.
Yeah, that'd be all right.
That'd be good.
I
We
could do
could do
that. I
that.
could do that.
So again, in that, Brandy, I really liked how you said, knowledge is power, and I've used that same quote a couple times in my office. They used it on the video too. But Katie, if I may, just recently kind of talking about this and going through this, did you really feel knowledge was power right at the beginning? Because I know a lot of people who I work with, knowledge is scary.
Knowledge is very scary. After leaving multiple appointments about all this, they send you home with that binder. And to be honest, I didn't read it. I set it on the counter and I said, cool. Like, I just couldn't go through it because it was too much to process at the time. But then I eventually did go through it, and my mom was a big help. My husband was a big help processing it. When it came time to talk to my dad about the gene, we just went straight to the basic facts. We went basic with him. I felt like that's all he needed. And then the rest of the information was for me. So knowledge is power, but it's also extremely overwhelming, especially when they send you home with 4 binders. So, yes.
I saw a brother of a male gene mutation carrier, and the brother told the brother about his mutation status through a text. And it just said, I have a mutation, go get tested. And the brother he screenshotted the text and brought it as part of his health history. And I just thought it was really interesting how, it's fun to pick on males because I'm a male, but when it comes to health stuff, it's like 2 cavemen grunting at each other and go get tested, go get tested. And it's a different approach depending upon who you're talking to.
Right, because the rest of my family, my aunt had been tested, and we had discussed this in length with her and my cousins and my brother. Like, they were all cool. We want to know about this, but with my dad, we really had to take the basic approach, and that's all he needed. So.
And as you get into that further, would you say that the knowledge is a little bit more powerful than when you first heard about all of it?
Extremely, yes, especially now for my children. Now I understand when they can be tested and how I can be proactive for them when they get older. And so, yes, now I feel like I have the knowledge that I need that is powerful.
So question for you, Dr. Avery. Since you're seeing patients, when do you introduce the idea of genetics? Because you may have a patient sitting right across from you who just got a diagnosis. You need to talk about 100,000 different things. When do you talk about genetics?
And that's a perfect question, because as if you or a family member or somebody has sat in one of those rooms and we start talking about it, man, we talk about everything under the sun. We talk about your job and your work and your schedule, and we talk about cancer and what's adenocarcinoma, what's ductal versus lobular, what's all these different minutia that a lot of people don't care about. Well, we care about it, and we have to know about it to risk stratify and to go through all of that. But genetics is ultimately on some of the forms that I initially talk to people about, and I really at the beginning often say, we're going to come back to this, because we can't talk about surgery and chemo and risks of this and lymphedema and, for all the various cancers, all the different aspects to that. So just because your provider hasn't brought it up, if you're ready to talk about it, you can always bring it up, because they're probably thinking about it too. But just this one conversation all by itself, it's scary and it's hard, and there's a lot of information. 4 binders, they were really nice to you, because I mean, it can be a daunting task, but I kind of like the old saying, how do you eat an elephant? Well, 1 bite at a time. Just like taking on the rest of this. It's just 1 step at a time, one bite at a time to get that information to understand all of this. So we're going to open it up to the audience a little bit more and go through, how can you begin the conversation? What are concerns that you have with your family members? What are concerns that you have with extended relatives, or questions to ask, and how can we be a resource for you today?
We talked about this a little bit ahead of time, but I thought it was so interesting, and other people might be interested in knowing too. So I had the BRCA testing about 10 years ago, but you were saying that it's important that if you've had it a while ago, that obviously there's been new mutations, there's been new discoveries of how to identify those, and so it's not a one time and you're done kind of thing.
I just focus on cancer genetics, and it's just a rapidly growing field in research, and it's now touching, well, it has been a while, but it's now touching and even treatment options for people that have cancer. And so, but yes, BRCA1 and BRCA2 aren't the only two genes that can cause an increased risk for hereditary breast and ovarian cancer. There are 19, 20, 30 other genes out there. And now I'm seeing a lot of women that have had BRCA1 and men that have had BRCA1/2 testing in the past coming back around for follow-up testing, and we're identifying the CHEK2 mutations, we're identifying PALB2 mutations, all these newer genes that are being becoming clinically available. They were around a while in the research realm. They've been studied for maybe 10 years or so, but they haven't become available clinically, something that we can order in the exam room, and those are coming out now. And so testing may be recommended for a lot of people that have originally had negative test results.
I think generally, if anyone was tested prior to 2013, it's a safe assumption they probably only had BRCA1 and 2 testing. If they've been tested since, they might have had a smaller, maybe a breast-only panel that's maybe 5 to 8 genes. But like Bronson was saying, we're looking at panels now that are 28, 30, 35 genes. So,
and even if that comes back negative, you still may be, we're looking at, it's headed, this is where it's headed, and this is where it gets terrifying. Hopefully I'm retired by then, but no, I'm kidding. We're going to just look at the whole genome, your whole genome, 20 to 30,000 different genes. And then it opens up a conversation about, well, if we're going to test you for hereditary cancer, what if we find out something else that you weren't even looking for? Have that conversation. And there's a list of conditions that if the laboratory or if your provider identifies a mutation, then we have to tell you. And you have to tell us in advance whether or not you want to know. And so it's a very long conversation. And that exome genome testing involves testing other family members as well. We're like, the old phrase when I'm trying to triangulate your position. Well, they actually do that with genome and exome testing, where they involve 2 other family members and see if what they're finding in you is also seen in other family members. And so it's quite involved. It can be done right now. Insurance companies aren't quite on board yet with paying for it, but it's coming. More time to his consultation. He's going to have 2-hour oncology evaluations.
So that's where I was going to kind of make a comment on that as well, because all of what we're really focused on right now is talking about genetics and your familial risk factor, an abnormality that passes from one family member to another family member, or can actually just start in one person and then go down the line from there. One of the things that people often ask me about, or I often talk to them about, is there's more than just genetic testing of your family traits. We also do a lot of genetic and molecular testing on your cancer cells themselves. So we take your cancer cell, essentially crack it open, look at the DNA, and find out how your cancer cell is different, how your cancer cell is different from somebody else's, and use those abnormalities against the cancer. And so there's, just to keep in your mind as you're reading about this and talking about it and going through that, sometimes somebody may understand a genetic test. Yeah, they tested my cancer. Well, that's different. That's a different topic for a different day that lasts a week. But I completely agree. As we get more information, not only about the family risk, that is also crossing over into my stream, where I'm really doing the treatment and changing the medicines based on the family risk and the cancer cells the DNA inside the cancer cells. And so it's fascinating how this all starts working together on that.
And I think that's important when you're talking to your families, because they'll say, oh yeah, we did that genetic testing, but it is the tumor testing, or it's Brevigen to see what the risk of recurrence is. It's not actually germline hereditary cancer testing. So I think it's important to make that distinction too when you're talking to your families.
And when she says germline, she means the DNA that you inherited from your mom and dad, versus the testing that Dr. Avery's talking about is called somatic testing, where they're testing the tumor itself, because that DNA could be different from the DNA that you inherited because it's gone through several different mutations, and that's why possibly the cancer has occurred.
Can you address the issue of cost of genetic testing?
Can anybody?
Yeah, right?
I'm sorry, please go ahead.
It was very expensive in the early 2000s. I don't know, did you have to pay for
So my mom, when she was tested,
I'm kind of afraid to hear what this
she
was.
paid $6,000 out of pocket for only BRCA1 and 2. And if she were to be negative at that time for one of those 2 mutations, then she could test further, but that would cost about $20,000 per gene as you continue to go. So thankfully, she came back with that BRCA1, so we had an answer. Then when it came time for me, I only did that single site, only looking for the one gene that she had. At the time, it cost, this was prior to 2013, a lab had a patent on the genes. I paid about $700 for my test now. Now, if I were to go back and be tested today, and like all my cousins were just tested, they paid nothing, 0 out of pocket. Unaffected women, often if you have family history and you're meeting certain criteria, it's a covered service under the Affordable Care Act. So most women are paying nothing if they meet that family history criteria. Men, unfortunately, you're covered for maternity, but you're paying your deductible for this kind of testing. So we still have work to do when it comes to that. But I will say I have a little bias, but I started a charity to help pay for the testing when it's not covered for whatever reason. Medicare, if you have not had cancer, even if you have a known mutation in the family. So when we went to test my grandpa, we knew my mom was a carrier. We knew my grandma was negative. This research study indicated my grandpa was positive. His Medicare would not cover him to be tested, even though we knew essentially it came from him, because he personally has not had cancer. Medicare will only cover if you yourself have had cancer. So we have work to do in that realm too. But my charity, what we do is we pay for the testing 100% when it's not covered by insurance for whatever reason.
And then there are a couple laboratories out there that have a self-pay option as well, where you don't run it through insurance, and it's between one lab it's $250, the other lab is like roughly $400. And then what happens is you collect the person's email address the same time you collect the blood sample, and then you enter that person's email address and they get an email with a way for payment, essentially.
That's what my mom did. When my mom was diagnosed in 2003, 2004, it's been so long ago, they offered genetic testing. Our family couldn't afford it, so she just didn't do it, which is sad.
So
and then
foundation should fix that problem.
Right. And then when she was diagnosed the second time, we still couldn't afford it. And then when my grandpa passed away from pancreatic cancer, her doctors strongly advised we do it. We still couldn't afford it. So she found the lab that you do the self-pay. I think she paid like $150, but she could only afford to do, I think it was a 7 panel. Yeah. And that was 3 years ago, and that's already outdated. So.
I have a question. Brandy, so you pay for the testing. So if somebody is positive and they want to do preventive surgery or whatever, would that be covered through your funds also?
Unfortunately, we aren't big enough yet to be able to do that. What I found is that most people who test positive have no problem getting surgeries and those kind of things covered. You're subject to your deductible, but you're subject to your deductible with most things. So like when I went in for my preventative mastectomy, I paid my $5,000 deductible, and that was it. And that was all my surgeries, all my breast MRI, everything in that 1 year was all covered.
But you bring up a good point for people who are underinsured or have no insurance. That is a conversation that you and your healthcare provider should have before giving that blood sample, because it does start that process. If a mutation is identified, your healthcare provider is going to be making recommendations for management, and if you don't have insurance, those procedures will not be covered unless you get on a state-run service or something, like Every Woman Matters.
Right.
Or
I was going to bring up Every Woman Matters. Is that statewide or is that?
It is a statewide program, and we do have MRI testing for those that are high risk. But you do have to meet income and insurance guidelines for our program. We do have a website too. If you just Google Every Woman Matters, it'll come up as the first search.
Okay, there was a question in the back.
Okay, so I wonder if the general answer to this is going to be talk to your provider, probably. But I was just wondering if you can give any guidelines. And I know more about breast screening than the rest, but I know, like with a lot of the breast genes, it has to run within a lineage, so your maternal or your paternal side, and there's certain cancers that are related to each other. And there's so many genes out there now. This might be a hard question to answer, but is there any way that once you talk to your family that you can generally know, like, well, they had skin cancer, liver cancer, these types of things. Like, are there any that that you can say these go together or these go together? I mean, it might be too hard to answer, but there might be too many answers to that. But is there anything for people to generally know as they have those conversations?
The more and more we research melanoma, colon cancer, breast cancer, endometrial cancer, the one cancer that a lot of people, right now cervical cancer, has shown through a lot of research is not associated with an inherited susceptibility to cancer. So cervical cancer is more related to HPV and other non-hereditary risk factors. But to answer your question, a lot of the cancers that you just listed on there are listed as cancers that are seen in hereditary cancer syndromes, so that all of that history is going to be helpful to contribute. And so, a lot of pre-test genetic counseling, at least here in Lincoln, there is no cost to doing it, and so you can have someone take a look at your family history and give you you meet criteria for testing, or kind of give you that once over that should be no problem for you.
For other things like colon cancer and things like that, like I know my mom just talked to an oncologist about possibly getting tested, and they decided that her treatment plan probably wouldn't change depending if she found out,
You're right.
she's already doing everything that she would normally be doing, so she opted not to. I'm wondering about, I know with breast screening it does, but do cancers like colon cancer and stuff, do they say like, will your colonoscopies be covered at an earlier age?
Yep.
Like,
So right now there's a recommendation that if you have a first relative with colon cancer at any age, you should start your colonoscopies at age 40 instead of waiting until 50. And actually they've moved and correct me if I'm wrong, they've moved the baseline age for colonoscopies to 45 instead of waiting until 50. And so knowing your family history does, just helps when it comes to everyday screening.
Now that also, the patterning, seeing a pattern go through the family, really Bronson's going to be focusing on that, because he's going to make this cool little pedigree, which is a picture of mom and dad and yourself and grandparents, and it's a fun little picture to look at. But you can see this pattern of different cancers as they go through. For BRCA, for example, that patterns differently than something called Lynch syndrome. That patterns differently and has different cancers than other cancer syndromes like Li-Fraumeni and these different things. So not just focusing on breast or ovarian or colon, really focusing on all those different cancers, cancer types that are in your family history. And going to the second question, without knowing anything else about the family, about that person's care, is again, it does go back to the more we know about someone's cancer, the better. And in some cases, even in colon cancer, there is more overlap needing to know about their genetics to change their treatment. But then there's some genetic testing and molecular testing of the cancer cell that we can do, and so some of that might have been done, but there is additional things. Everybody's hearing about immunotherapy because right now they're advertising it out the wazoo.
Yeah.
everybody thinks everybody and their dog should be on that. Well, they shouldn't. There's the majority of breast cancers that probably won't do anything with immunotherapy. They just won't be that helpful. But there's some cancers that, shoot, you just sprinkle in a little bit of immunotherapy and it's wonders. Some cancers just behave differently and need different medicines. And so we just need to know everything about the genes, the family genes, and the cancer genes.
But for your mom, this is me totally playing devil's advocate, and because I'm affected by it. If your mom's doctor talked to her about it and her only hesitation is because it's not going to do anything for her treatment, she might meet guidelines for testing, you might not. And sometimes we used to relative chase, Bronson can probably attest to that, where we would only test the affected patient. We would only test the person that had cancer because they've had the cancer, they're most likely to carry the gene in the family, right? It might have huge ramifications for your family, but also like if she has colon cancer now and she had Lynch syndrome, she might be at risk for ovarian or endometrial cancer. If she still has those organs, I don't know a cancer patient in the world that wouldn't say their worst fear is that of getting another cancer. And if that test could give her those answers that she's at risk for that, that might not necessarily change her cancer treatment, but might offer her some surgical options to prevent another cancer. So I would encourage her to think about it again.
And even just to alleviate anxiety. You know, cancer sucks, and it's really, really scary. But to relieve some of that anxiety, saying that I don't have this and I've been tested for that, it can really help.
The only other thing I wanted to ask was about insurance issues related to genetic testing. Can you address that a little bit, the impact of results on future health insurance purchases, life insurance purchases, et cetera?
There's a federal law that was passed in 2008. It's called GINA, the Genetic Information Non-Discrimination Act. And you can go to the website called ginahelp.org for more information. But in a nutshell, it states that health insurance companies like Blue Cross and Blue Shield, United Healthcare, they cannot use genetic testing information to make coverage decisions. Likewise, employers cannot use genetic testing information to make hiring or firing decisions. But there are caveats to that law. Right now, that only applies to employers who have 15 or more employees. Also, it doesn't apply to life insurance, long-term care insurance, and disability insurance. Those three policies can use genetic testing information to make coverage decisions. And so I always tell people that before they do genetic testing is if you were planning on opening those policies after you got your results back, do the testing first, then go and get your results, and then get those policies opened up. Or sorry, flip that around. Open the policies first, then do the genetic testing. Sorry, if that makes sense. Your genetic test results, to my understanding, shouldn't affect any policies that you have. Again, I'm no health insurance lawyer, but it's my understanding that they can't affect ones that you have open already, but any one that you open in the future after you get those results back could potentially be used against you. And I get a lot of questions like, well, how do health insurance companies get that information? Do you send them my results? No, we don't do that, but some policies do require some medical record review where you sign an authorization for them to review your medical records, and that's where it potentially could come up. Now, like I said, I've been doing this for about 13 years. I haven't had anybody come back and say, I haven't been able to get those policies or I've been denied those policies. My concern is they may have a higher premium for them compared to someone who may not have a gene mutation. Again, I don't have proof of that, but that's where the potential exists.
We went to the legislature a few years ago, so I professionally work in politics. So I worked with some state senators to propose some legislation to prevent life insurance discrimination, and it was killed almost immediately for the fact that nobody's even asking the question about, have you had genetic testing? Do you have a mutation? The question's not even being asked. The questions that are being asked are regarding family history. So what came first, the chicken or the egg? You know, the people that are meeting guidelines for testing are the people that have cancer history. And that's where people are getting dinged on that life insurance. So how I look at this is my son will probably answer the questions about family history, cancer history, a lot different than I will. I have to put, my mom had breast cancer at 35. Hopefully my son won't have to put that. And so if we can kind of change the course of that, I think it'll help generations downstream too. Thank you guys for having us.